Good afternoon, everyone. I'll quickly run through a case of ocular Behçet's disease, a rather atypical presentation of ocular Behçet's and how we seek the help of a rheumatologist. So he was a 37-year-old gentleman who presented to us with diminution of vision in his right eye since 1 week and left eye which was there since 6 weeks. He had no other complaints at that time, but he was a type 1 diabetic who was on insulin for 8 years. So he had shown elsewhere and he had come for a second opinion where he was diagnosed as diabetic papillopathy and left eye optic atrophy. There was no other significant positive history that he gave us apart from an episode of pancreatitis in 2018. So coming straight to the fundus examination, what was classical that was appreciated here was that there was presence of a hyperemic disc with disc edema, which was more so in the inferior-temporal region, along with the presence of a few telangiectatic vessels. No obvious inflammation, no vitreous inflammation was there at presentation in the right eye. His near vision was slightly compromised. However, the left eye had significantly reduced vision, no inflammation in this eye as well, but there was optic atrophy which had set in, and there was an incomplete macular star at presentation. After taking a closer look, we appreciated that there was an atrophic patch which is present superior to the disc, possibly an old healed retinitis lesion, and that was about it. But there was no strong positivity towards an infection, or are we dealing with a non-infectious condition. Coming to the OCT parameters, they were as what we had observed clinically, a localized disc edema in the inferotemporal region and a resolving macular star in the left eye with the optic atrophy. The visual fields in the right eye showed depressed points superiorly, and the left eye was compromised severely. So at this stage, we did not know what we were dealing with. It was was it infection, was it non-infectious? So we thought of going ahead with the fundus fluorescein angiography. So along with the clinical findings which we had appreciated, that is the presence of these telangiectatic vessels, we saw some perifoveal leakage, that is a capillaritis which was present. So we thought of revisiting the history where we were thinking there is a neuroretinitis-like presentation here, but not fitting in exactly bilateral. So we asked him if there was a history of any recent fever in suspicion of neuroretinitis. He denied. However, what he did tell us that he had episodes of genital ulcers which were multiple recurrent over 5 to 6 years at the base of the penis and scrotum. So we had genital ulcers at this point. However, the eye presentation was not very classical of Behçet's. So at this point, our provisional diagnosis, a working diagnosis, was bilateral neuroretinitis-like presentation, and with a differential of infectious etiology or possibly Behçet's, but we needed more supportive evidence, and we started the patient on tablet doxycycline 100 milligrams twice a day, and asked for a routine investigation to rule out any infectious etiology to start steroids. So TPH and HIV were negative. And at this stage, we did ask him for a history of pathergy. We did a pathergy with a 26 gauge needle on the forearm, and it was positive with 3 mm of erythema. We added oral steroids here, and at 2 weeks, the disc edema had started resolving. The telangiectasia had resolved. But what helped us clinch the diagnosis is that during the course of treatment, he developed oral ulcers. So now we had genital ulcers, we had oral ulcers, and papillitis, which was present, is a rather uncommon presentation of Behçet's. So we were more in favor of Behçet's and went ahead with an HLA B51 and B5. It turned out to be negative, but at 1 month presentation, his disc edema had resolved in the right eye with some pallor, and his vision had stabilized. So with this presentation, his score was about 7 with the international classification of Behçet's disease, and we took help of our rheumatologists. The patient was started on methotrexate and double immunosuppression with cyclosporine 50 milligram once a day, and the steroids were slowly tapered off. This is his 9-month presentation where he doesn't have new lesions, new ocular lesions, no new oral or genital ulcers. His ESR is normal, no capillaritis on the FFA, the way we monitor Behçet's ocular wise. And so his cyclosporine was tapered and
Sayali,
now continued on methotrexate. So my questions to the panelists are, what is their choice of immunosuppression in the ocular phenotype of Behçet's? And few anecdotal reports have said that cyclosporine should not be used. However, some reports say that cyclosporine is in fact the drug of choice. So I would like to know regarding the same.
Yeah, I'll go to the questions first. And regarding immunosuppression, cyclosporine can be used. Actually, it's a choice of drug for ocular Behçet's. So it's preferable. We give cyclosporine and methotrexate as you have given, and azathioprine is other drug, because if it is the posterior part of uvea, it's better to go for azathioprine, and if the vasculitic involvement is there, azathioprine or cyclosporine is the choice for ocular Behçet's. Anterior uveitis, methotrexate, yes, but okay, methotrexate, cyclosporine is also given. And regarding the contraindication, I think maybe it has gone through that papillitis because optic nerve is involved. So probably you might have thought cyclosporine can be given or may not be given. In the case of neuro Behçet's, if it is a neuro Behçet's, yes, cyclosporine is avoided generally, because the toxic symptoms of cyclosporine, the neurotoxicity, might confuse us with the symptoms of Behçet's. So, and there are also case reports where there might be like exacerbation of neurological manifestations of Behçet with cyclosporine. So in this case, since it's an optic nerve involvement, papillitis is there, like you have not given any history of headache, confusion, tremors, seizures, etc., which can be attributed to the neuro Behçet's. So probably we presume that there might not be neuro Behçet's. So I've given cyclosporine and it has worked. So ocular Behçet's, no problem with cyclosporine. It's clearly the guidelines mentioned to use. And neuro Behçet's, no. And second thing is how, like I'll just go back to your case. Like genital ulcers, there are few things which are not very clear in your case. Like you said, the few years before patient has genital ulcers, and it's just history. We would like to know like how it has improved, what kind of therapy he has taken, so that
he would say that it would resolve on its own.
Spontaneous.
Yes.
And one thing, like little bit odd thing, what we felt is the patient on steroids has developed oral ulcers. So generally, it's a bit unlike.
It was within 2 weeks of initiating oral steroids that he developed oral. Actually, that's where we felt like we were dealing with Behçet's.
So yeah, overall, if you club the things, oral ulcers, genital ulcers, it fits clearly. But the natural history, if you see the past history and 5 to 6 years before, how it has improved, and now the present oral ulcers, so these things needs to be looked into. I think you can go back to the questions. Yeah. Second thing, how do we monitor the progression or stabilization? I think the eye part, you have to give us information. And as I said, because the optic nerve is involved, we would also like to look at the neurological part. Initially, the symptoms. If the symptoms are suggestive of anything of neuro Behçet's, we would like to go for the imaging of the brain. And monitoring, yes, if the eye is becoming quiescent, especially in these cases, again, Behçet's is like disease of waxing waning. They'll have few years of acute phase, then later on they might go into remission for a very long time. So, like I think if the patient is in remission, we can continue the drugs for a period of time, like at least for 2 years. And the first thing to be stopped is steroid. So once we stop the steroid and the patient is quite stable for a very long time, say for 2 years, then we can slowly de-escalate the therapy of the immunosuppression if the patient do not have any other systemic manifestations. How to deal with ocular systemic recurrence? Yes, if the patient, suppose if this patient has not responded to methotrexate cyclo combination, yes, anti-TNF would be a preferable choice, infliximab or adalimumab. And how do you rule out, and suppose if the patient has not responded to anti-TNF, again we have drugs like anti-IL-6, tocilizumab has been tried in certain case reports, and we have newer case reports of using tofacitinib in these cases. How do you rule out neuro Behçet's in case of papillitis? Yes, we have discussed if the symptoms clinically, if the patient have any symptoms, and imaging. So there are specific features like vasculitis is seen and diencephalon involvement is seen. And if because Behçet's can cause thrombosis, any sagittal vein thrombosis, if these are the clues which tell us probably we are dealing with a Neuro Behçet's. And other thing is the vascular component. Nowadays we can also see femoral vein thickness by doing an ultrasound. These things also do help us whether we are dealing with an overall Behçet's or not.
Thank you.
I think, Dr. Lisa, you have...
A small thing, B51, I would not, it's like a straw because it's a clinical diagnosis, you have nebulous things, you want to make a diagnosis, but it's not a very strong diagnostic test, and I don't think it's included in the score either.
Yes.
Why did you do a homocysteine? It was 32.
Yeah, because we initially were thinking of neuroretinitis and we did not know what we were dealing with. For this patient specifically, homocysteine was done as a battery of investigations from the lab. We did not ask for it from wherever private lab he had gotten his investigations done.
So interestingly, the homocysteine is 32.
Yes.
So look at the B12. You have a diabetic, you have oral ulcers.
So in
A rheumatologist is a physician. The last bastion of general medicine is rheumatology. So when you look at this picture and you give us these oral ulcers and genital ulcers and all that, first always rule out, general causes before you go. So when you walk on the road, the most common animal you see is the dog, not the elephant.